Yes, and we are live as well. So, good morning, good afternoon, good evening, everyone. I'm happy to welcome you all to this first live TBPPM Friday Forum. The TBPPM Friday Forum, as many of you all know, has been a text-only interactive session on the TBPPM Learning Network website. But many of you suggested that it will be good to make it more interactive. So we decided to make it a live forum discussion that will be closed, and it'll be a very informal format, more like a fireside chat around the topic. And it appears that that's the way it is right now, with just few of us joining. But everybody is welcome to raise their hands during the discussion time to share your thoughts. The chat function will also be open if you want to interact with other participants. And do not hesitate to share any ideas, because any and every ideas are welcome on our platform. And yeah, so we just want to have a discussion around this topic on integrated service delivery. Just a few rules: that the meeting will be recorded, and unless you are speaking, kindly have yourself muted. If you want to raise a point, kindly raise your hand, and the moderator will call upon you. So to introduce today's topic and to moderate today's discussion, I'm happy to introduce Dr. Uzma Khan. Uzma is a physician and a public health professional working in TB control in lower and middle income countries. She has extensive experience in overseeing, implementing, and conducting TB research, and has provided technical assistance to TB programs in Asia and Africa. And she's also currently doing that. She's also a member of the Regional Greenlight Committee for the WHO Euro region. And we're so glad you're able to join us, Usma. So over to you to moderate the session and introduce the topic.
Excellent. Thank you so much, Joel. And thanks everyone for joining. I hope we'll have more people coming in. But since the theme is also such and the whole concept is informal, again, just to reiterate that we'll keep it informal. And many of you, some of you I know, and many of you I know of, but I haven't met. So to start off with our topic today, we have a few panelists as well who have been kind enough to offer their insight, especially with their work. And I'd like to invite them for some of the questions. But then we'll also open the forum as a side, as Joel mentioned, that you can raise your hand and contribute in for any questions and anything that you want to provide more insight about. So to kick off, the first question, I'd like to invite Suesh, who has worked in Nepal, and he has a tremendous experience as well in working in TB control. So Suesh, what do you think? Why do you think we should integrate TB services with other programs or diseases?
Hello, good morning from here, and namaste to everyone. Thank you for the question, and thank you for inviting me, first of all. So when we talk about tuberculosis, we all know that Mycobacterium tuberculosis alone is not sufficient to cause TB disease once it infects someone. So there are various underlying factors that leads TB disease from the infection. So the factor can be if someone is malnourished, if someone has immune compromised states like HIV, if someone is pregnant, if someone is a child, which is mainly under 5, if they have a chronic disease like diabetes, cancer, chronic kidney disease, or being a smoker. So there are multifactorial that causes TB infection to TB disease. So if TB program wants to end tuberculosis, then they can't work in silo now. Because all of those factors are dealt with different health sector and different health program. So they need to integrate, like for child health and maternal health, they have to integrate with the child health and maternal health division. For the HIV, they need to integrate with HIV program so that they can initiate the bidirectional screening as well as referral. And they need to integrate with non-communicable disease, especially if they want to target diabetic patient, where they also need to be screened, as well as smoking cessation program. And there are a lot of other programs like IMNCI, which are being conducted in developing countries like Nepal, where there is an integrated management of child and neonatal care, where TB needs to be screened for all those severely acute malnourished children for tuberculosis. So I think these are the key reasons why TB program needs to integrate with health program. And when we talk about health program, there is a huge private sector in contributing to the health system in Nepal, as well as in other developing and other countries. So if we fail to cater that, and if we fail to integrate private sector as well to fight against the tuberculosis, then we'll be missing a lot of people, as the private sector has a huge catchment area. They have multi-specialization. The private hospital, medical college, small clinics, and pharmacies are the place where many presumptive TB people goes finally, and where they are screened and may also missed. So I think these are the main reason we need to capture those TB cases services, as well as integrate private health program as well in the system. So I think these are the key areas why it's very important to integrate TB in other health system as well as private program as well. Thank you.
Thanks, Suesh. Wonderfully comprehensive, like summarize in terms of why we should do it. And there's so many zillions of reasons that we should do it. And we all agree. I think another question that comes into my mind as well is that this policy to practice issue, which is a problem with implementers, how to understand how can we do it into practice, and what does integration mean even, when you talk about all these different programs, because they're all like sometimes in certain settings, they work in vertical programs, right? So what does integration mean, even like, in a concept, how does that work in practice? That is an example. So I could ask, anyone in the forum to contribute, or Suesh, you, but anyone has any idea on what it would look like in terms of, just overcoming barriers, or showing an example of what it means to actually integrate?
I think I would like to just share some experience regarding the integration, and I would certainly, seek help from other experience also. So when we talk about TB needed to be integrated with health system, it's eminent, we have to do it. But when it comes to the practice, I think the biggest challenge is, the coordination and collaboration between TB program and other programs. For TB, tuberculosis is very important, but for other program, it might not be. Like for maternal child, they have other priorities than tuberculosis. For chronic diseases, they have other priorities. So they might not think TB as a priority. So when we approach them to integrate and try to collaborate them, TB might not be their priority at first. So this is the biggest challenge that even we saw when we wanted to integrate child with tuberculosis in IMNCI, as well as, in a pediatric case management. But I think to address this, I think it needs to be, one of the biggest, national TB program has to take the leadership in this. So once we went to the family welfare division, we had a lot of collaborating meeting, and after that they finally agreed to include tuberculosis as a part of their IMCI screening and training. Then we went to the Nepal Pediatric Society. So that's why collaboration with private organization association is very important. So Nepal Pediatric Association, they also took it very nicely, and they helped us to develop the guideline. So once all the pediatricians were on board, then it was easily also integrated in the other guidelines, where they are also helping us to train. So I think to integrate TB service, a national TB program has to take a leadership, has to go and ask every other health program that this is the importance, that's why this needs to be integrated. And overall, I think it needs to be also leadership from the national priority. If TB is a national priority, then it will be translated in all the national strategies, and then integration is easy. Yeah, that's all from my side.
Thanks, Suesh. Nice example of how integration can happen, especially with collaborations. Rabia, do you want to chime in? Is there anything that you have in terms of an example, especially from your experience in Tanzania? Rabia, if you're talking, you're on mute. Okay, we'll see if Rabia can come back to us. Curie, is there anything from your experience in India? And I know you've gone through a major challenge of being a survivor of MDR TB, and that's a huge in itself in terms of experience. But learning as like the challenges of barriers to accessing care for people in the system. Have you had any experience that you would like to share?
Now, like, how do you integrate TB services with other programs? Since I have to talk on that. So it's like most of the programs or anything we see around, it's more about like more about like controlling TB patients. It's not about providing care to them. So like planning these programs definitely requires some thinking minds, but when you have to implement this program, it requires thinking and caring minds. So you cannot integrate TB services into any program with this control mindset. And the caring model demands to address other aspects which are beyond treatments. Like, for example, like medicine can treat the disease, where but there are other socio-economic aspects which also people need to address, and these are the issues which often means those issues are not addressed. So in order to integrate this TB services with the other health program, you have to make it a point that there is a regime which is like holistic. It treats patient holistically. It's not only addressing physical symptoms, it is making them holistically healthy. So this is how I think it should be done.
No, absolutely. And I think this should, you completely agree. And it's an extremely important point. We see that a lot itself, like this TB is a social disease. You need to address so many other barriers in accessing care, not just towards, and integration does not just mean disease integration. It also means integration with other aspects, like, where you need to, so we don't talk about a lot of non-health factors actually, where you need to kind of, if you have social welfare organizations, if you have other literacy, health literacy is an important thing as well, right? You talk about social support and we always say, okay, let's get funding or something, but you have other people who are, especially in a lot of our settings, who are always working in providing social support and doing charity work and other things. And some of those complementary activities can be synergized, and real integration can happen there as well. But there's so much work, I guess, that needs to be done. So Rabia, you're with us. Anything that you want to add?
Thank you so much. Greetings, everyone. And this is Rabia. So maybe specifically in Tanzania, when we are to look at the integration, so far the TB program is doing well in terms of integrating TB and HIV, but also now integrating the non-communicable disease like diabetes. It's also doing well. But also integration in the reproductive health, child health, meaning that there is TB screening at the RCH, which is going to load the QI, or the quality improvement approach. But also there is the issue of TB and mental health integration, to which now we have this methadone clinic. So it's also really helpful for the integration. Although, of course, there are some other things which are really hindering the process, including the limited healthcare workers, maybe in provision of psychosocial supports, especially when it comes to sober houses. But also issues of education is also a challenge because of limited awareness among the community is unaware. So sometimes it's hard to provide. Issue of high level of stigma is also a problem. Financial constraints and poverty, as we know that for us, we are still into the poverty issue. That's a problem also. So moving forward, we understand that TB is everywhere and anyone can get TB. We need this thing of integration to ensure that maybe the issue of cost effectiveness of programs implementation can also be good. Issues of reducing loss to follow-up, for example, maybe if TB HIV are integrated, then obvious issue of reducing loss to follow-up disease can be also be good, other than being into one single portfolio that can be bad. Also looking at this situation of pandemic like COVID-19, it's good to see that now the NTP program has integrated this, and there are some of the guidelines which are supporting the process. So it's really nice to see that, although really huge work needed to be done in terms of the supervision, management, and so issue of coordination, plus also systems. This is really needed. So maybe I can stop from there for now as we move forward and continue.
Thanks, Rabia. That's some excellent points, especially in terms of optimizing resources when there are resource constraints and everyone is trying to understand how we can get more funding to do all the work for TB activities, which sometimes it's very important to understand that they can't completely be integrated in everything, and you need extra support, especially when we know that there are so many social issues to address as well. Zuena, I noticed that your hand was up before, but it's not anymore. Would you like to add something?
Well, thank you. But I think Rabia says it all. We are all Team Tanzania. So as she said, NTP Tanzania has integrated TB HIV, TB diabetes. Those are the ones which have official guidelines, but there is quality TB detection in all entry points, even though it's not that really much integrated. And it's very important. Integration is crucial due to resource constraint. So I think that's why we need to integrate TB in with other diseases. Thank you.
Thanks, Zuena. And Petra raised a question in the chat, and I was just, where does the responsibility of TB programs end when we're aware that integration is important to address social determinants? Anyone wants to provide some insight?
Maybe I can try to address that, but not completely, So what Kayuri raised, I think it's a very valid, issue that's serious. So Nepal is also implementing a program called InTB initiative, and we are planning to InTB in certain palikas at the moment, and then moving forward. So ending TB is not ending TB by medicine or by giving preventive treatment. So TB needs to be ended with all other social causes. So when we planned the NTB proposal, we wanted to integrate with, poverty alleviation program. We wanted to integrate with agriculture program, and there are so many areas that we needed to be integrated. So at the end, where we knew that it's needed, but TB program or NTB manager alone cannot do. So we went to the Prime Minister, and then the Prime Minister issued a statement saying that TB is a national priority and we'll be ending TB by 2035. So after that, the initiative took place. The funding also came from the government side, and we are implementing TB-free initiative in a few palikas. So I think in order to integrate and to address other social determinants of tuberculosis, I think the leadership of the country plays a bigger role. So if they are interested and if they are willing, integration is possible, and ending TB implementation is also possible. So I think that is the experience that I had, and I just wanted to share that.
No, Suesh, excellent point. Political will is like a priority when you're talking about, elimination potentially, and you're talking about providing services beyond primary care, what primary cares can provide. So that's an extremely important point. I want to also go back to some of the challenges we're talking about, and when we talk about integration, because from my experience, what's really hard is there are funding gaps are always there, but we also do a lot of burnout to existing health systems. There's a lot of health system strengthening that's required already, because primary cares structure is not well developed. And we're working in a vertical program in many countries as with TB systems. And when we talk about integration, you're already working in a structure where there is not enough resources. So we create more burnout. Is there anything that we could do in terms of creating some kind of sustainability? Is there any experience that people have had? And also, secondly, any good experience from integration with COVID as well? Because, we always say that it can't happen. And then suddenly COVID happened. And in many places, we did have to integrate. So if there's any insight into some of these health system strengthening issues, where we also, are required, and how, resources can be shared, and some examples from any of your programs. Anyone can, by the way, from the forum can chime in. So not just Suesh, Curie, and Rabia, and so everyone else can chime in.
It means you are asking that how can we integrate our current ongoing other health system programs with TB services?
I'm saying that there are barriers that exist because you don't have a lot of resources in a lot of these countries in terms of providing quality, equitable services for TB. And when there are vertical programs that are supporting excess funding, but when you talk about integration, you're almost trying to optimize resources, but there is risk of burnout as well in terms of doing that. So how do you kind of make sure that integration happens without compromising quality, without burnout? So Petra.
Well, I have my hand up, but it wasn't really related to the burnout. I think it maybe it is actually. The point that I was trying to bring forward is that I think and I'm talking more on the side of the possibilities of what is an opportunity. When I listened to Subesh and when I listened to Rabia, it struck me that the more we are localized, the more we are at a district level or at a local level, the easier it will be to think holistically, because we better understand what really the issues are. Is it malnutrition, or is it a social safety network, or is it HIV, or is it that we're talking about a mining population, or are we talking about rural, very far away, not access? It's easier to identify what needs to be integrated. And I think the failure is that when you talk about, or the stress comes when you talk about integrating the silos at the national level and kind of forcing that down at every area. It doesn't make sense to say from a national level, HIV and TB need to be integrated if HIV is in an area not really very prevalent. So I think the opportunity is to really localize it. And this brings me back to Curie's point. We're all talking about the same person that we want to care for. So if we deal with people that are also smoking or are really worried about their food because they simply don't have access to food, then that would be an issue as a TB officer that I need to be taking care of. And yes, it will. If I take it all on, and this is why I asked that question, where does our responsibility end? I care for the person, so I want them to be healthy, and only providing them with TB medicine might be stretching a limit if I know that there's other issues that will make them sick. And I think that's where I think your question about burnout is really much bigger than the integration of services, because the care for a person and wanting someone to help people, want to help a program to instill that in the different health systems is I think we simply don't care enough. We, meaning the world, we don't care enough about health of people. It's so easy to look only at the financial outcomes, but to put more money into care, the people that care, the healthcare workers, often don't even get paid. They do it voluntarily. So I would make a point that, catching up on Curie and what others have said, that if we invest more in care at the center of our thinking, it will also help with linking you back to the burnout. But now I'm really rambling, so I'll stop talking and I'll let others.
No, you're absolutely right. And as Curie has added also in the chat, that responsibility ends when patient gets cured, and that's the unfortunate part of it. Zwena, do you have anything to add to the same thread?
Yeah, thank you so much. Something also struck to me when Petra was talking about the localization, and I was thinking, now what will be the role of the local, and the national level role? Because come to think about it, at the local level, using my experience, at the local level, for example, in my country, at the dispensary levels, the relationship between the patients and the caregivers are actually person-to-person relationship. They're actually managing the patients as persons, because they are few, they know each other. So somehow they treat them, or they manage them integrated somehow, but they don't have, there's no maybe formal guidelines, or they don't have that much capacity how to manage them more effectively. But come to see of it, at the local level, at the dispensary level, at the village level, the relationship between caregivers and care seekers are really people to people, personal kind of relationship. Like they're really taking care of a person because they're really close to each other. But now, what is the role of the national level, like to capacitate those healthcare providers? Because someone is like in my village, they will know, they respect the care providers. They know each other, and they know their problems. Like they know when I go there, they know what is Zuena's problems, like that, holistic. Yeah. So, but now, when at the national level, when we talk now about integration and all that, what will be our role now to think what this is happening down there? Thank you.
No, absolutely, I agree, and this is an important point itself, and coming, it kind of links to what Petra was also saying, and I want to go back to talking about the community part of it, because real integration does not happen. My belief is, and I think we'll all agree, that if it doesn't happen at the community level, at the patient household level. So a lot of the integration piece is being done, and the decisions are made at provincial or national level, and involving communities or mobilizing community into these topics happens in a very fragmented way. We talk about advocacy. Advocacy happens at different, sometimes it happens, sometimes it doesn't happen. It's not really consolidated in any form or shape, and giving more opportunity and empowering communities is really important, I think, to also let go of the control that Curie mentioned earlier on, which I think creates a lot of stigma, especially when we talk about DOT and other things, and the way there are ideas that are potentially stigmatizing as well, while the concept might not be so. So I think integration has a lot of place. It's an important concept, but it's deeply rooted in some of these ideas and approaches that one needs to make, which are very context different. I mean, Suyesh gave some really exciting examples in Nepal that are happening, which can be adapted in other settings, but standardizing it, would not be possible. And that's why we need to come up with context-specific ideas in different countries. So next we should, I wanted to, talk more about integration across private providers and inclusion of private providers. I know a lot of our countries that we have, worked in or where we are living have a huge private sector, mostly unregulated, unfortunately, and but we do work with them, and there is a way of project wise we've had sets a lot of examples in terms of how they can contribute in terms of case finding especially, and then also follow up. But I want to raise a question that in terms of integration, there are so many gaps in terms of where you can integrate with private providers and where you can't, and it has not happened really, even in the most ideal of settings. Are there any things that you want to talk about in terms of successes, but also challenges that we still need to overcome?
Maybe I'll just give some example that we did. So for writing the new funding mechanism for Global Fund, we went to private sector and said, this is the scenario where we are missing the cases. We think that private sector is catching so many cases, And then Nepal Medical Association doctor, one of the doctor raised his hand and said, national TB program always says private sector is doing this, that, but what is national program doing to the private sector to bring them abroad? We are always been discriminated in terms of that. So if you look at the training, the national training is always focused on the those who are under the government's jobs and all those people, but private sector are always left. If you look at the distribution of the gene export or other diagnostic facility that government gives, it's always concentrated on the government sector, and private sector are always left. So if you expect something from private sector, you need to also make the private sector, part of it, and not leave it, and also only expect them to give. So I think this was a very good, thing that the doctor from the NMA told us, and that is something we also wanted to reflect in our new funding mechanism. So private sector has to be there if we need to, increase the access and availability of the services, TB services especially, and integration really helped, because we integrated TB in pharmacy. And once we started pharmacy referral, then the huge number of presumptive TB were identified, and more than 4,000 cases were identified from the pharmacy itself in a year. So we can see that, there is a cases in the community. People are going to the pharmacy, and once the referral begins, we can find the cases. But as long as we don't integrate, as long as we don't think private sector as a part of our system, and only think that it's their mandate to give us the cases, then I think it doesn't work. So it's a two-way stream that has to be concise in one way. So I think we need to also give private sector the same advantages and same benefit that the government sector is getting. Yeah, thank you.
I completely agree, Suresh. This is such an important point, because and we've been talking about it for so long, and that there needs to be a relationship ground of mutually agreed principles. And there can't be a one-way kind of dynamics. And we've suffered a long way. I don't know, in terms of TB, especially, and certainly for drug-resistant TB as well. We're still so far away, and there's a huge AMR issue that we should be talking about in terms of antimicrobial resistance, and how a private sector is still not a part of this. How to contribute in terms of not just case finding, but management for drug-resistant TB, especially when we talk about decentralization and true decentralization. So it's an important thing. Zuena, I don't want to take up all the time talking about this, but Zuena, you had your hand up.
Yes, I have an example. As you said, if we have an example, in Tanzania in 2018, the NTP provided 4 gene expert machines to private hospital, big private hospitals in Dar es Salaam city, which is the biggest city in Tanzania. And the reason being, in Dar es Salaam, they have almost 76% of the healthcare facilities are private, and about 36% of people face sick care at the private hospitals. So it is obvious you need to support the private sectors. And luckily enough, it's because the government has regulation and has a policy, has a policy for public-private partnership. So this regulation makes it easy for any disease when they want to integrate or they want to collaborate with the private health facilities. Thank you.
That's excellent, Zuena. And if you could just, or maybe Rabia can also add in terms of how that happened, that partnership and that policy, and what it took to be in place. Not just, obviously, it's amazing to have that, but especially if others can learn from this.
Yeah, maybe I can add, because I was part of the team at that time. So it was just immediate after the WHO roadmap for the private public partnership for the TB. So that's when we, as a program, we consulted the Ministry of Health. So the Ministry of Health called the private sectors. So they have their organization, the umbrella organization. So they were called, and there was a meeting, and the roadmap framework was developed. So one of the decisions there, of the agreements there, is that the government needs to support the private facilities. So that was one of the output of that collaborative framework between the Ministry of Health and the private healthcare organization. Thank you.
Okay, thank you. Rabia, you had your hand up.
Thank you so much, and thank you so much, Zuena, for the good points. So she talked more on the national, what the program is doing. So I also wanted you to bring in the perspectives view on the community. So here we need the integration of private healthcare providers, because first of all, it will increase coverage and bring intended services close to the community, because at the end of the time, then time to access the services will be saved, issues of people-centered will be resolved, but also issue of providing friendly services to the beneficial, especially the KPs, will also be resolved, because sometimes people do fear to reach the public facilities due to the disclosure which might be there. Maybe someone is an FSW, female sex workers found with tuberculosis, and people might end up talking about him or about her and such things. So many of them tend to learn to the private facility where they think that it's more secure for their secrets to be kept out. But also, once we are to engage them, we feel like private health facilities offers less bureaucracy, and most of them, they are flexible. Sometimes they're flexible. You can access services anytime which you want, and we can see those facilities which have been engaged into provision of TB services, they are really so supportive, and that's why we call to strengthen this engagement. So that was the point of view of the community perspective, what we need when we are to engage the private facilities. Yeah, thank you.
Thank you, Rabia. Anyone else who has anything to add? Aarti, I know you joined, and welcome. Is there anything that you'd like to bring into this discussion from a community perspective?
Yes, good evening, ma'am. I am Aarti, TB champion from Touch by TB. Ma'am, I can't speak English perfectly.
No problem.
मैं हिंदी में बोल लेती हूँ, आप ट्रांसलेट करके बोल दीजिएगा.
No problem. Yes, बिल्कुल मैं बोल दूंगी.
एक्चुअली मैम हम लोग ग्रास रूट पे काम करते हैं टीबी पेशेंट के साथ. तो अभी हम लोगों ने काफी सारी प्रॉब्लम्स देखी पेशेंट के लिए, जैसे कि जो एमडीआर टीबी के पेशेंट है, जो जिनकी फैमिली में वही कमाने वाले हैं, हम लोग जैसे स्लम्स एरियाज में काम करते हैं, तो मैम उन लोगों को प्रोटीन नहीं मिल पाता है. जैसे कि जो बीमार पड़ जाते हैं टीबी पेशेंट जो कमाते हैं, अगर वो ही कमा नहीं पाते हैं तो मैम उनकी सिचुएशन बहुत ज्यादा खराब हो जाती है. हमारा मोटिव ये नहीं है कि सिर्फ मेडिसिन ही दे हम लोगों को, और थोड़ा मैम कुछ हो सकता है टीबी पेशेंट के लिए तो उनको फूड प्रोवाइड भी किया जाए.
बिल्कुल. Yes, yeah, बिल्कुल सही कह रही हैं. So Aarti was explaining to us that from the community perspective, there are so many barriers that are just much more monumental in terms of the social barriers, that socioeconomic barriers. So they're not able to feed themselves. There's so much poverty, and there's so much vulnerable populations, and certainly they need a lot more support. And and I think that's an important point, because sometimes we talk about giving a standardized approach, and everyone says one size does not fit all. I think it needs to come out in policy, and not just in policy but also in implementation, that individualized care is really important, especially when you have some of the most vulnerable and those who are homeless and those who are with comorbidities, when we talk about integration, I mean, the holistic care, when you talk about diabetes, they're talking about, people, not just their sugar, but also potentially their renal functions and other things. So everything comes into play. And I feel like this is an extremely important point in terms of integration, and what Petra was saying initially as well around community-based work, and how to destigmatize and empower communities also equals empowering communities, right?
और मैम एक चीज और, जैसे कि निष्क्रिय पोषण योजना के तहत 500 रुपीज दिए जाते हैं पेशेंट को, तो वो सारी सुविधाएं भी उनको नहीं मिल पाती है। कई पेशेंट ऐसे हैं जिनका ट्रीटमेंट कंप्लीट हो जाता है, उसके बाद भी उनके अकाउंट में पैसे नहीं आते हैं, तो उस चीज के लिए भी हमें कुछ करना चाहिए मैम।
Yeah, so Aarti was just talking about barriers in terms of not being able to get the social support, which is already allocated sometimes due to whatever the systems might be in different countries. And I think that's an issue that we have seen elsewhere as well. But when we talk about integration, we also should talk about equity. And because I've seen that when we do projects, for example, we do projects and we say, okay, we're going to do this for this person in order to ensure that they adhere to this treatment. We need to do this, and we're going to provide the social support. Whereas there are other patients who might be coming in routine programs and who don't get that. So, and how do you create this equity then? And I know that it's very easy to talk about sustainability, but these are models that you need to not just test, but also test in a way that they are scaled up so that all your services are provided for everybody. So I think integration in terms of what is everyone's thoughts about this, in terms of when we talk about social support, and which is a big issue, and how projects come in with different needs, different things. And we talk about sustainability, which is one of the things that one wants at the end of it. And domestic funding is not really completely always available. And sustainability means integration in a more comprehensive, optimized way. So how can we, what kind of barriers would one face? I mean, is there anything that you imagine you would face, like in your programs, in terms of when excess services are provided one project, and how that can be scaled up?
I just want to, add whenever we are designing the project, especially I work for Global Fund, so sustainability is the term that always, give us a big headache, because the things we bring bring into the proposal is from the country dialogue, going into the community, their needs, and if their needs is something that has to be catered. And if someone comes and says that if you give this now, how can this be sustainable later? But I think if we cannot control it now and only think about the future, then that is also not sustainable, right? So it's better to control now, giving all the benefits that you have to that patient, and then control it rather than giving later. Like Aarti said, we went to the country dialogue and we talked with the one people who is 24 years old with XTR. So when we went through the file, he had MDR, but he left the treatment in middle. Then he had pre-XTR, and now his XTR patient is still living in a hostel. And the main reason is he's the bedrunner. So he had to go to work and he cannot stay in the hostel, and the minimum 5,000 rupees given is not enough. So if we don't support that person now, thinking about sustainability later, then that person either transmit and at the end dies, right? So I think sustainability is good, but I think we need to be very contextual, in terms of sustainability. And if it is going directly to the beneficiaries, like patient, I think sustainability is something that we need to think later rather than now, because it has to be given. Yeah.
No, I think you're completely right. And I think we all agree on this. I think the problem is when you discuss with donors, like you said, it's extremely frustrating. And I hear you, I've gone through this, trying to restructure a system, trying to say that, okay, let's talk about context specific things, and people come with standardized approaches, because policy to practice means a standardized policy. Whereas contexts are actually so much diverse and different, and the needs are so different. And when we talk about social disease, TB being a social disease, it has to have context. It can't be in a standardized way. So I completely agree with you. And I would argue and agree with that the expenses that one has to put in terms of providing care, effort, decreasing transmission, and providing the best treatment are maybe far more in the first few years, but there are huge gains in the long term in terms of cost effectiveness. So, I think that's important to understand, especially at country levels as well, the investments when they are put in terms of efforts. Zuena, do you want to chime in on the same topic?
Yes, thank you. The socioeconomic barriers, really, like Ati has said, for me, I look at it like it's like we are closing our eyes on that issue. Even when we are writing proposals and we are given ceiling, the percentage you are being given for the allocation, for the case findings and all others, they are much, but for the social issues, they are less. But also this goes, this is where TB cannot fight alone. You know, this is where multi-sectoral collaboration comes in, because these are more cross-cutting issues. And as you said, their programs, maybe they get more because they're silos program. And how can other program gain? This is where, as a government, need to stand up and provided leadership, that committed will, you know, to make sure that these issues are being addressed. Otherwise, we will still be singing these issues like every day. Thank you.
I completely hear you. So I think, but I do think we need to continue to sing these issues, even if we have to. I mean, I'm a huge proponent of that, because sometimes it is taking time, but I think we all need to be advocates, bold advocates, not just advocates, but bold advocates for some of these issues. And it comes back to the same issue around health system strengthening and talking about the fact that TB funding should not be a TB as a silo. If TB Reach, for example, is coming up with a funding program for a project on integrated services, it's thinking out of the box, and it's amazing, and kudos to them, because, you know, the conventional donors only support TB. They don't support hepatitis C. There are so much hepatitis C in these are high prevalence, some of these high prevalence countries that we work in with TB and hep C. They don't support diabetes. COVID there was a pandemic, so it became like, an important disease area. But I think out of the box and, is not just a term to use. It has to be, conventional donors need to also move towards more, different ways of doing things and of business. And we should all be bold advocates of that. It's important right now. COVID really taught us that. I think one thing is that advocacy is extremely important, especially in our area of TB. We have we still have a long way to go, but I think it has been a very insular community over a long time. Forums like this, and thanks to Petra and Joel and all of the other people, are places to kind of talk about these things and generate more voices. Anything else that people would like to add to some of the concerns that we have, shared, or success stories, or anything else that we'd like to discuss around integrated healthcare? We have 9 minutes, so the floor is open for other people to ask questions.
Yeah, I'm just going to call on a few people to see if they wanted to add. Golibe, I know you've been one of our active participants in our course. Do you have any thoughts to add on about integrating TB services and why it is important to integrate TB services?
Thank you very much for that. Yes, I believe that integrating TB services is really important, because I think I see it from the area of stigma. Where we work in the private sector, TB still gets a lot of stigma, and people don't want to be affiliated with the disease, or that they are treating those that have the disease and all that. So the only way I feel to fight the stigma would be a proper and true integration. And the point is that with the reduction in stigma, we will see an increase in awareness. Once the stigma and the fear of something reduces, people now seek to understand it more. And with the more knowledge they have about it, it also reduces the stigma. So it's like it's a snowball effect. The more you integrate, the way the stigma reduces, the more knowledge people have about it, and also the more the stigma reduces. So I see integration as the key rock to not just reducing stigma in addition, but also to also increase funding. You understand? When it is part of the system, all those funding for diabetes and all that is just part of it. There was a little study we conducted where we looked at the chest x-rays of people, of patients that we suspected may have TB. We ran their chest x-rays and then we found out that these are TB suspects or TB presumptives, like we call them. But when their x-rays were analyzed, about 16% of them turned out to be positive for TB. But 30% of them had cardiovascular symptoms like, hypertensive heart disease and all that. So you find out that with the proper integration, sometimes even when somebody is being screened for TB, other disease conditions can be discovered. And at the end of the day, they can be treated all for the well-being of the patient. So I think for me, integration is like the way forward. That's the only way we can actually move ahead, providing holistic care for the patient, because most of the things we are doing is just for the patient. Thank you.
Yeah,
Thank
thank
you.
you.
Over.
Okay.
Thank you. Excellent point. I just want to add to that, true integration is important. Sometimes I feel like we have tried and a lot of people want to do integration, but creating a one room in a building where, everyone has a lot of tertiary care facility, and then you have one TB clinic, but that TB clinic actually has zero links with the tertiary care facility, is like not where we want to go. We want integration, and we should try, because it becomes competing interest for other people, because you're taking resources from them. So that integration has to be on a mutually agreeable, beneficial kind of platform. And extremely valid points by, yeah. Yeah, go ahead.
So it's all about collaboration and making sure that everything is mutually beneficial to everyone. Yeah. Okay.
Absolutely. It's the same thing that we were talking about the private providers, where it needs to be at the, everyone has a seat at the table, so to say. And because there are interests that are both sides, and we, not just the patients, obviously, that are constantly being decided by other people, but which also needs to be a part of integration in terms of understanding what the needs are at the community level or at any household level. Some of the needs are not understood very well. So I think there's many aspects of integration that needs to be layered on, but the bottom-up approach is probably something that we all agree would be more beneficial. Kiri, do you want to talk about these points?
Well, I just mentioned it over here. It was just coming to me, so I thought I'll just put it down. So this is...
Yeah, collaboration, I think, is the key. And in terms of also addressing some of the barriers, talking to everybody, communication, I feel like ground level, that communications and having participation somehow is, there's less, in TB programs. I don't know how people think, but do you think that there are less focus on community advisory groups or community, having more community participation as a part of TB programs?
I think communication is something which should be developed, because it's like a TB patient are like I agree that the people who are treating TB patients are very busy people and all, but it is just uncomfortable for them to give their time. But the real uncomfortable people are the patients. You are busy with your work, agreed, but you are not as uncomfortable as patients. So communication should be improved in this. And because once the communication is improved, people will be able to open up to you, and they will tell their problem, what is happening, and then I think that things will move further quickly and in a positive way. And it will also improve cure rates and all. That's it.
Absolutely, absolutely. I think everyone needs to be an advocate, not just especially the clinicians on the ground who are treating. They need to be the advocates for their patients. So completely right. So we have a few minutes. Any last words? Or Joel, is there anything that you were going to say?
No, Uzma, I just wanted to thank everyone for participating today. It was a really nice, close-knit discussion. It was more like friends chatting together around this topic. So I'm so glad that you were all able to join. And I think, Uzma, especially thanks to you. You did a fantastic job in moderating the session. I'm sure everyone agrees that you kept this interaction very live. So thank you for your moderation.
Thank you
And
for inviting.
I think one of the advantages of having this close-knit group is I can thank everyone individually. So Suresh, Kyuri, Aarti, Zuena, Rabia, Tulani, Zodi, and Golibe, thank you so much for participating today. It was so
You're
wonderful to
welcome.
hear. Yeah, it was so
Thank
wonderful
you.
to hear all your points and all your experiences about this important topic. And just to add to what we've been discussing, I think right now this is more important. And like Uzma mentioned, I'm so glad that TB Reach is doing this, because one thing that we heard from people during the COVID-19 pandemic is when people cough, automatically physicians started to think of it as COVID, and they completely ignored the TB at one point. So that was also contributing to the rise in TB cases. But I know many of us are health practitioners, and we have treated patients also. So the first thing that you do is to have a differential diagnosis. You will have a whole set of differentials for which you would need to have that open mind to know that it could be anything. So I think integrating these TB services is gonna really help in having a holistic approach like what we've been talking about. So thank you all for participating today, and all your responses will be available on our Learning Network page on the Friday Forum page, and we look forward to seeing you all in the other Friday Forum discussions as well.
Thank you
Thanks,
all.
everyone.
Yeah,
Thanks,
good day.
Joel.
Bye.
Thank you.
Thank
Bye.